Good afternoon, everyone. Welcome to today's Research America Alliance discussion. My name is Trent Carlson, Associate on Research America's Policy and Advocacy team, and I'd like to thank you for joining on Zoom today and for your partnership in the Research America Alliance. If your organization is not a member, I hope you'll reach out to Kristen Furlong, Director of Membership and Development, whose email is or should shortly be in the chat for information about the Alliance. Today, we are joined by Dr. Stephen Mathai, Associate Professor of Medicine at Johns Hopkins University and part of the Johns Hopkins Pulmonary Hypertension Program, and Shavini Fernando, founder and CEO of Oxyware, who developed a device to monitor oxygen levels after being diagnosed with severe pulmonary hypertension. Dr. Mathai and Shavini will share their experiences in treating and living with pulmonary disease and highlighting promising advancements for patients. As always, please type your questions into the Q&A box or chat, and we'll get to them during the audience Q&A portion of today's session. Thank you so much for joining us, Dr. Mathai and Shavini. As someone who has been a caretaker of somebody with pulmonary disease myself, I jumped at the chance to moderate this discussion. So I'd love to get right into it. To start off the conversation, Dr. Mathai, could you give us a sense of what pulmonary disease is and what toll it takes on the American people, and maybe also the toll that it takes on caretakers as well?
Well, thank you. First of all, thank you for the invitation to participate. It's an honor to be here and to speak in this forum. Lung disease is any process that affects lung development and or function. So lung development, begins in utero. And while that process is started in utero, it really doesn't end with full lung function until someone is in their 20s. So longer than we might think. It's not just through adolescence but young adulthood before we reach full lung function. So exposures, whether it's exposures to air pollution or toxins, some genetic predisposition, other environmental factors can impact the peak of lung function that any one individual might reach. And then beyond that, exposures, genetics, other factors can impact lung function going forward. So it's not only from where you lung function decline, but also thinking about where you're starting from as a mature adult. And it's important to note that with normal aging, there's loss of lung function. So after your mid-30s, with aging, everyone loses lung function. The rate of lung function decline can increase with certain exposures. The most commonly the thing that has been best described is with smoking. So if you smoke tobacco, you have a twice-fold increase rate of lung function loss. So double the rate of lung function loss with smoking. So what does that mean? We think about the epidemiology or how many people in the United States might be affected by lung disease. It's more than 35 to 40 million. So 10%, maybe even up to 15% of people live with chronic lung disease in the United States. Most commonly, we think about asthma and COPD as those diseases, and up to 27 to 30 million people in the U.S. with asthma, another 10 to 15 million with COPD. And you can see, there's a huge burden in terms of the sheer numbers of patients affected by these chronic diseases. And it's not just the disease itself and the impact on the individual from a symptom standpoint, but thinking about the cost. It's billions of dollars a year to care for patients with asthma or COPD, and a huge burden on the healthcare system. But even beyond that, thinking about, as you brought up, the question of a caregiver and what the impact on a caregiver might be. We don't have great data across the spectrum of lung diseases, but looking at COPD patients and the caregivers for COPD patients, studies have demonstrated that about a third of caregivers develop health issues of their own that can be attributed to caring for someone with chronic lung disease like COPD. There's a social impact. Over 80% of caregivers report impact on their social lives and functioning as a result of their caregiver responsibilities. And then close to 40% notice an impact on their work, as you might expect if you're caring for somebody while trying to maintain employment. There can be an impact on that. So I think those are the three areas which we most commonly see it. The health issues that I mentioned also include mental health issues, anxiety, depression that can be experienced not only by the patient, but also by the caregiver. So hopefully that gives a little overview of the kind of the impact of these diseases, not only on patients, but also on the health system economics, and also caregivers.
Absolutely. I know I find that incredibly insightful. And every time I get onto a call with you, I always try to soak up as much as I can. So, in addition, could you take a moment to just talk about the current research gaps when it comes to pulmonary and lung diseases? Um, and please feel free to share ongoing research projects in your pulmonary medicine lab at Johns Hopkins.
Sure, sure. So, I think there are a lot of gaps in our understanding of all lung diseases. So it's very difficult to, in general, speak about these, but I'll try to highlight a couple things in general that are perhaps uniform across disease states within lung diseases. And we're talking about things like COPD, asthma, lung cancer, other more rare diseases in the lungs like interstitial lung disease or pulmonary embolism, PE, or pulmonary hypertension, which is my area of focus. Thinking about the gaps there, most of the time, what resonates across these is early detection, early intervention, effective intervention. So thinking about how are we going to identify patients earlier, and there's actually a lot of equipoise when we think about that, because to identify disease early often involves testing. And there's a cost, not only a financial cost, but a patient cost at the patient level. Is it necessary to undergo these tests? Are we going to get, as I like to say, is the juice worth the squeeze? So are we going to find enough? Is it going to be sensitive enough or useful enough as a test to identify disease that we're not going to be overly burdensome to our patients and caregivers? So that's an important factor to think about. And are there risks involved with testing? So these things we have to balance. But in general, there are programs in place for early detection of COPD, of lung cancer. In my particular area of pulmonary hypertension, we are trying to focus on patients who are at risk of pulmonary hypertension. So patients who have underlying heart disease or lung diseases like COPD, like ILD, might be at higher risk for pulmonary hypertension. So how do we identify them? And then once we identify them, how do we treat them? Most of the interventions we have for these lung diseases, for these more complex lung diseases, focus on more advanced stages of disease. So thinking about, if we identify somebody early, are the same treatments effective? Is the side effect profile of those therapies, does it warrant trying it in someone who has less severe disease? Or do we have to develop totally new therapies to treat an earlier stage of disease? And that balance is something that we struggle with and something that we need to focus on going forward. And then obviously developing effective therapies. Now, when I say that, there's curative therapies, right? That would be the goal. We could diagnose a disease and cure it. There are disease modifying therapies. How do we make the disease stop or regress? We improve the disease without curing it. And then there's symptomatic treatments. What are the major manifestations of these diseases? Can we improve shortness of breath? Can we improve cough? Recognizing that we may not be able to achieve all three of these in any individual person, but that should be our goal. And then, I should even take a step further back and say prevention. So preventing lung disease is a great focus of research and public awareness campaigns. So I mentioned smoking. If you don't smoke, your risk of COPD decreases exponentially, as an example, right? Your risk of interstitial lung disease is lower. So things that we know can lead to these diseases, we should also have educational research programs to intervene at an early age with our children and youngsters, saying we please recognize the risk you are causing, the potential harms you are exposing yourself to by these behaviors.
Thank you so much. Shavini, I would love to hear a little bit more about your background and what drove you to get involved in this arena.
So by background, I am no medical professional. I'm a video game developer. And I ended up here because I had a congenital heart disease. I had a ASD, and I was a swimmer and I was a sprinter. I had no idea I wasn't supposed to do any of the two. And I got diagnosed only back in 2015 when I damaged both my lungs and the heart due to overdoing it. Because see, when you're an athlete, when you're tired, you think your cardio function is bad, you train more, but you
Right.
don't assume that something's wrong with your lungs and the heart. So I came to US for a second opinion from John Hopkins, and I was diagnosed with Eisenmenger syndrome with severe pulmonary hypertension. So as someone who's so I was tied to full-time oxygen, I'm severely hypoxic, and because I shunt sometimes, so then I don't get oxygen at all to the body. So I was on full-time oxygen. But the thing is, because I'm so hypoxic, I've had multiple episodes where I went into cardiac arrest and strokes because of hypoxia due to cerebral edema. And I needed to figure out a way that I can still live my life,
Right.
but without risking it. And then I learned the only way to know it is knowing how my oxygen levels are fluctuating. Because I don't feel my oxygen levels falling. I'm physically fine because most of us patients, we are so accustomed to live with low oxygen and we don't feel it when it drops really low. Like my doctor at John Hopkins get really panicked because I can't even function with 50% oxygen. I have no physical symptoms until I end up with something life-threatening. So that's why I made this device which can continuously track my oxygen levels and just give me a timely alert before it hits below the life-threatening levels. So it's just doing your first aid, quickly grabbing your oxygen, cranking it up,
Mhm.
and having the enough oxygen that your body needs. Or if you think it's too late, call 911 and get the help before things go into really life-threatening situations. And then even for doctors, it's easy for them to understand exactly what happened at that time. Because when I go to ER, I'm the last person most of the time they listen to. I try to explain that it happened because my oxygen dropped too low, but no one listens to me because no one believes that I managed to stop a stroke by cranking up my oxygen and doing everything that's needed. So, so the whole purpose of doing this was to just empower the rest of the patients who's like me
Mhm.
to go out and live their life without having to define their life with the disease that they're diagnosed with. Because having a disease shouldn't stop your life. You should still be able to enjoy your life. You just need the agency to know when to stop.
Right. Right. No, and that is incredibly inspiring what you've done. I will note, although we don't endorse any specific
Yeah,
company, it's good to know that
yeah.
there are
That's why I
options
didn't say
out
any
there for
names.
patients. Yeah, right, right. So just one last reminder before we get to this last question, to please feel free to drop any questions you have in the chat. Um, this is a question that's for both of you. Could you tell us more about the challenges in getting oxygen that patients need? What are the challenges that they're facing? How did we get to where we are now? And what do you perceive as the biggest challenge in conveying the significance of pulmonary diseases in the US and the importance of ready access oxygen?
You want me to start or you?
Sure, go ahead.
See, first of all, my oxygen is not covered by insurance. Right. I have two oxygen concentrators, and none of the oxygen concentrators or the parts are covered by my insurance. So it's all out of pocket. And even though our oxygen levels are low, we look quite normal. We don't look sick. So people don't even realize that we need oxygen and we have underlying disease because it's silent. So I think one of the biggest issues is the awareness, because people don't understand that there are people whose biggest issue is just breathing. right? Until the moment they can't breathe, they won't understand how significant that problem is. And for patients, once you choke once, you don't ever want to choke again. But the problem is everyone who makes the policies, who writes the policies, who allocate the budget, they haven't gone through it. So I think the people who needs to be there where the decisions are made are not the people who understands the need of it. So when people don't understand, they don't make the right decisions. They don't allocate the budgets. So, and like most of the time, I think the diseases like pulmonary hypertension, ILD, they're very underrepresented, like, public health discussions. They're not included in most of the funding or the policies like that they prioritize on. So, but there is a large number of patients. I think it's the lack of awareness and not being represented, and those who make the decisions. I think there's lack of education and awareness part in where the decisions are made on the top levels. I think that's what needs to get updated first.
No, and to your point, Shavini, there around 2 million people in the United States on supplemental oxygen outside of the hospital, right? So it is not an insignificant proportion of our of persons in the United States who require home oxygen. And there are some challenges with that. As you alluded to, there have been changes over time, largely financial in nature, that have led to insurance companies deciding to support certain devices and to not support other devices. And I think what isn't taken into account as much as we would like is the patient perspective. So Trent, to your questions before about kind of our research in this area, we've had a couple of studies where we've just tried to understand better what patients are experiencing. Right. So what are the challenges that they're experiencing and what are their perceptions of using supplemental oxygen at home? And what we found is that a couple of very interesting things. So first of all, from a patient perspective, the mobility, portability of these devices is not sufficient. So for instance, if you have a device, if you require more than 2 liters per minute of flow of oxygen, your device automatically is going to weigh more than 10 pounds. Mm-hmm. Right? That doesn't sound like a lot until you have 10 pounds strapped around you for 24 hours a day, or you have to move around with that on, or you're doing that with some underlying health issues, whether it's your strength, your coordination, et cetera. So the portability of these devices is a major issue. And the availability of devices varies based upon your insurance coverage, right? So you might find a real nice device, but it's not covered by your insurance in terms of the portability aspect. The second thing is thinking about the duration. How long do these devices last when you leave the home, right? And that's going to be directly proportional to the flow rate. So if you're at higher flow rates, you need more than 4 liters a minute, 6 liters a minute. Those portable gas tanks are going to last less than an hour, right? So you have to think about then in increments of time, increments of tanks, how long can I be out safely and not get into trouble with my oxygen. So I think those are two of the major things on the patient side. On the provider side, where we fall short, we recently did a study looking at the records that we keep about oxygen and how it shows up in the medical record. And we're terrible at it. The prescription that we actually write for the patient only appears in about 20% of the charts, right? And our communication with the patient about what flow rate should be used, with what activity, at what time, night, day, etc., sleeping. We don't do a good job of documenting that either. And that's a major problem if we think about this. When you go to the patient side of that, most patients, more than 2/3 of patients, just adjust their flow based upon how they're feeling. Right. And to Shavini's point, that may not be related to their actual oxygen levels. And that's something that I think needs to be dispelled, that there is an association between shortness of breath or other respiratory symptoms and your oxygen levels. Because while they can be related and can correlate, many times they do not. So you can feel severely short of breath and your oxygen levels are fine. And conversely, you can feel completely fine, like Shavini was describing, but your oxygen levels are very, very low. So you can't conflate the two. So I mean, that's an important lesson for us to learn.
Absolutely. So we have some very good questions in the chat here. Let me start with this one. Have there been any congressional hearings on oxygen availability that you're aware of?
I don't know if Shavini can speak to this from personal experience. I don't know if you've done any work on the Hill, Shavini, but I'm happy to talk about just the general.
I know there was one that was hosted and everyone supported, like COPD Foundation and PHA and all, where patients and everyone went in. And in addition to that, I don't think there was much into my knowledge.
So there's a bill that's been introduced into Congress. It's called the SOAR Act, the Supplemental Oxygen Access Reform Act. It was introduced earlier this year. So we'll see how that progresses. But in general, the goals of that bill are to address some of these issues that we mentioned regarding access to devices, oxygen supply, and delivery devices, regardless of insurance, to kind of make a standard about access. And then another big part of that, so that there are four, I'll take a step back and talk about the organizations to which Sravini was referring: the COPD Foundation, the Pulmonary Hypertension Association, the American Lung Association, American Thoracic Society. All of these organizations, there's a laundry list of them, have gotten together to say these are the four things that we need to do from a patient and provider perspective to improve the care of our patients who need oxygen. And those four things are: number one, to ensure supplemental oxygen is patient-centric, meaning we need to think about this as supplemental oxygen rather than home oxygen, to change this perception that if you're on oxygen, you got to be at home and you can't get out and do things. And then create a patient's bill of rights to ensure that care is focused on what the patient wants. To Shavini's point, we need to engage patients to say, this is the thing, these are the things that are most important to me, and this is, can we address these issues? The second pillar is to ensure access to liquid oxygen. So liquid oxygen is something that used to be widely available and now is not available in most states, in fact. And liquid oxygen is really unique in that it is a highly concentrated form of oxygen that can be delivered in smaller containers for a longer period of time. So that situation of a patient who's on 4 or 6 liters of oxygen per minute of flow, that 45-minute duration that they can have adequate oxygen delivery with a tank on a liquid tank, that would extend significantly. Now, there are challenges with liquid oxygen, which we can talk about as well, but from a practicality standpoint, that's important. The third thing was to create a statutory service element to provide adequate reimbursement for respiratory therapists. That's another thing that we think is helpful. It's not just giving the oxygen, but how best to use it. What are the strategies that a person can employ to improve their lung health and oxygenation? And then the last is to ensure predictable and adequate reimbursement and to protect against fraud and abuse, establish national standardized documentation requirements, to what I was referring to earlier about how we are not great at documenting, and then thinking about how best to actualize these claims for supplemental oxygen through our suppliers. So those are the four major things that are embedded in this bill. And I would encourage you listening out there to reach out to your congressperson to advocate for this bill called the SOAR Act, SOAR. And that's really going to be important for persons and caregivers of patients on supplemental oxygen.
Sure. No, and you know what? I've got another question here that I think we all can relate to in one way or another with all of the technology that's starting to get infused into our lives. We've got a question about the usefulness of smartwatches and monitoring oxygen and alerting patients to low levels. Can you speak to that and how useful those devices are?
So, because most of the time, currently in the market, all the devices, what they give us is just spot reading. And to get that, you have to stay still, keep the hand still, and our oxygen drops when we are walking around, not when you're sitting, and that then we are normalized. My oxygen drops when I'm climbing stairs, when I'm walking uphill. So that's what I need to know. So with this, while you are walking, doing your day to day, that's what I wanted to know. Like, how does my oxygen drop when I'm actually doing activity? Because that's the one that correlates to my quality of life, not when I'm seated and watching TV. So most of the others doesn't do this, but that's why we were the only ones to get FDA clearance for continuous measurements of oxygen during activity. So it was really tough because even for that, we had to educate the FDA a lot, because even the FDA didn't understand why someone needs to see their numbers during activity. And there was times I had to wear my oxygen and tell them it's because one question they asked me was, who needs continuously measured during activity? So I wore my oxygen on and said me. And so that's what I say, it's a very lack of education and awareness. Even if people at FDA doesn't understand it, what more can you expect?
Yeah, no, that's great. Thank you so much, Shamini.
Yeah,
Dr. Matai, okay.
Sorry, I want to just add some
Yeah.
things onto that. I think one of the things, as you point out, technology advances that we have failed to integrate into supplemental oxygen use are things like Shavini is describing with continuous oxygen monitoring. But on the other end is change in oxygen flow rate based upon that, right? And we can walk into our home and tell Alexa or Siri to turn on our lights, start the car, do all these things with our voice. Why can't we do similar things with our oxygen flow, right? Because as Shavini pointed out, at rest, she may not need as much oxygen as when she gets up. But in the current framework, what happens for a patient is he or she may be wearing oxygen while sitting on a couch and knows that they need to go up to 4 liters or 6 liters when they exert themselves, but they have to get up off the couch, go to the stationary oxygen concentrator and turn it up. So they're already putting themselves in a position where their oxygen levels are going to be low for a period of time while they're exerting themselves. So, integration of smart technology to overcome that would be a real advance in my opinion. And I think integrating our advances, not only detection, but also thinking about adjustment of oxygen flow rates is something that we should be looking to in the future.
Yeah, and to add to that, something I can say is like when our oxygen drops, the last thing we should do is walk around, look for our phone, and try to run to the room too. Because sometimes we have oxygen concentrating in a room and walk around with a 50-meter cannula.
Mhm.
So we need to run to find it, because oxygen is the heaviest device we use. And we are not supposed to carry heavy stuff. Instead, the oxygen is the heaviest thing we carry around.
Right.
It's funny sometimes. So that's why, like, even with the device, something I did was, as a patient, I understand what needs to be done. Like, to send my family member a text alert on where I am in case if I pass out, someone knows I need help. Because most of the time we pass out, no one knows we have passed out. Sometimes I wake up and call 911 on my own.
Incredibly scary. And, it would be great if we could get these kinds of answers for sure. So let me go to the next question here. Why do you think insurance, including Medicare, is not adequately reimbursing for things like supplemental oxygen? Do you think that impacts challenges with getting more innovation?
I do. I think Shavini might have more practical experience with her recent development of a FDA approved device, but I will say that the reimbursement
Yeah. There's no
profile,
codes.
yep, it's very difficult for us to navigate as providers. I will tell you that.
Sure.
There are multiple different codes, and what is going to be acceptable for one designation may not be acceptable in another scenario. And that's a very challenging thing to navigate. But I think it all comes down to, the money aspect of things and the cost, and trying to find a balance between, effective healthcare delivery and not wastefulness, which I do think, there can be some of that. But at the same time, we have to recognize what patients need and what they want, and find the best way to address that. Because, we cannot, as providers, keep someone pinned in their home because we can't deliver sufficient oxygen for them to get out of the house. I mean, that's just not a viable situation for anybody, and something that we hate to see as providers. So there are insurance realities that we need to address, and I think there are, like the SOAR Act, there might be some way to make sure that our voices are heard regarding the significance of these barriers that we currently experience.
Yeah, because I can add to that. There is no CPT codes to include for like continuous any respiratory monitoring or oxygen management at home. So they have not expanded those for those yet. And even now to get those done, like we're working to talk to insurance to literally show that, okay, by doing this, how much it can help them. It's funny that you need to show their monetary saving to get the reimbursement all discussed. So now we are trying to show that, okay, by covering this much for patients, this is how much you are saving. So it's sad because it all drives by how much money they are going to save, not by how much it's needed for the patient. But that's the current situation with policies and insurance and everything.
Well, it's good to hear that there are potential avenues out there that are going to be addressed. So, just a reminder, if there are any other questions out there, please feel free to put it in the chat. I do have a question here, and Shabini, maybe you can answer this one. What are the main touch points of advocacy to ensure that improved quality of life? How can we ensure that messaging on patient autonomy gets across to legislators and others out there?
I think one of the reasons, I think patients need to step up, because sometimes one of the things I've seen is patients, when they're wearing oxygen, for some reason, they don't want to go out and show. Maybe it just affects their self, like, the confidence level to go out, and they don't even like to wear the oxygen outside so that they get noticed. I think until we all step up and show the difficulties we have, we need to speak to ourselves. We have to, represent ourselves and say, like, look, these are the issues we have. So if every one of the patients who actually need supplementary oxygen, it's not just the doctors, not just the associations, the patients also have to step forward, because what everyone's trying to do is to get this cost saving and the access to oxygen for this patient community. So if those who are actually benefiting from it is not going to step up to this, it's a hard process for everyone. Because, like, for example, when I was doing this, the first question that everyone asked me was, who needs this? I haven't seen anyone wearing oxygen. I've only seen you. So who needs this? So that's the question everyone has asked me. And I had to, like, they were like, maybe you should find someone else to represent this company because you are not well. Those were the questions. And I said, if I'm not ashamed of my oxygen, what's your problem? So we need to step up to this as patients if we want to get this covered by the, the policymakers and the Congress. Because as long as we don't step up, it's hard to do it.
A wonderful message. Dr. Mathai, I know you touched on a little bit on stationary liquid oxygen. what were the main drivers in the decline of those durable medical equipment supplies and portable oxygen concentrators and the like?
Yeah, I think there were, decisions made at the insurer level to, consolidate potentially, not offer as many varying devices, because there are a fair number of devices out there, to improve, their ability to function as an organization. I think, i.e., the money that's involved with this, because it's expensive, and I'm not minimizing that. So I think some decisions were made on those regards. And I think liquid oxygen is particularly challenging to maintain, because there's a specialized delivery and handling for that, for liquid oxygen that differs from the gas tanks, and that's one of the challenges. And unlike the gas tank, the liquid oxygen can evaporate. So it's got a finite time of utility, and there's some practical things associated with it. The gas itself is extremely cold; it can cause severe frostbite. So there's some safety issues there. So I think in totality, without a large number of patients utilizing it, the company's probably said this is not worth the investment in infrastructure to maintain. So I think that probably contributed to this. There are certain states, as I mentioned before, in which there are liquid oxygen available, and I have patients who actually, get a supply in one state and will choose to vacation in another state where liquid oxygen is available, so they can, go on, get out of the house and travel a little bit. But it requires a lot of planning, and I think that's one of the other challenges here, is that the mobility is not just limited to in the house, out of the house, but even thinking about traveling. And I think that's another major limitation that our patients experience when they have supplemental oxygen.
Yeah, I can add to that, because it's funny, like I'm an international patient, right? I came from Sri Lanka. I was amazed, like when I came here, how all the international airlines provide you supplementary oxygen in flight, whereas the airlines in the US they don't supply the oxygen. You need to have your own personal oxygen concentrator with you if you need supplementary oxygen. But all the international airlines, the first thing they asked me was, do you want to switch that off and use our oxygen, so you save the battery when you get down and you have to walk? So I think there's a lot of changes that needs to happen. And because if you check most of the outside countries, literally, like if you take India after COVID, when they understood the need of oxygen, they literally changed the whole supplementary oxygen, like all the infrastructure to get them out to patients, and they increased on it. But I think USA is like one of the top countries in the world, but it's sad to say that they are still far behind when it comes to these things.
No, if there aren't any last questions in the chat, I'm not seeing any. I'm going to ask one more, and then I think we can probably close out. With an overall shift to non-communicable diseases spurring a host of respiratory conditions like long COVID, how can we affect change both at the community and national level to address oxygen inequity?
That's a very good question, and something I don't have a great answer for. But I think it all comes down to recognition of the issue, quantification of the magnitude of the impact, which is on the research side of things, but that includes not only from a healthcare economic standpoint, but thinking about patient burden and caregiver burden. And there's emerging research looking at the burden to the system, and our communities as a result of respiratory diseases, and including things like long COVID. And I think that once that is quantified, it's much easier to go to our policymakers and say, okay, this is what we're seeing. These are the impacts. This is our potential solution. Because I think just going as without some sort of specific data to try to convince policymakers to change something is not a fruitful endeavor. So it's important for us to consider research at both at the provider level, the physician level, scientist level, and the patient level. Participating in research projects where we try to understand this is really important, not only for quantifying this, but also to potentially be used to motivate changes at the national level.
For sure. Shavini, any last thoughts for today?
And I think something we should put as a message is not to show it as the dependency on oxygen on people, but more on the point of empowering the patient with oxygen. Because you actually, if they have enough oxygen, you're actually a patient, like you're empowering them to go out and live their normal life. And most of them can return to their jobs and travel around and do their day-to-day things without having to always stress about whether they have someone with them if something goes wrong. So, and not everyone can purchase a personal oxygen concentrator. It's so expensive because it's not just the oxygen concentrator. When you're traveling, like I need to have an 8-hour battery, 2 4-hour batteries, and each battery is so expensive. And on top of that, every year you need to service them. It's like servicing a car. You need to change this. I'd say I'm maintaining my car. That's what I tell them, because it's maintaining my engine. I need to like change the filters. It's like maintaining a car.
Right.
Right. So there's a lot of maintenance. Not everyone can afford that. So there has to be a way that, and even the insurance, medicine expenses, patients have a lot of expenses. So on top of that, they can't afford this as well. And I think oxygen is a basic right. No, it should not be a luxury.
Well, thank you both so much for coming on here today and sharing both your insights and expertise. I know I really found it to be both inspiring and informational. So that looks like we're at time for today. Thank you to the audience for your thoughts and participation. Before you go, please take a look at the chat. Join us on December 3rd at 12 p.m. Eastern for a discussion with Dr. Alfred Sommer, Dean Emeritus, University Distinguished Service Professor, Professor Emeritus at Johns Hopkins University Bloomberg School of Public Health, and recipient of Research America's 2025 Outstanding Achievement in Public Health Award. In conversation with fellow Bloomberg School professor Dr. Scott Ziegler, Dr. Sommer will share insights from his storied career, from his life-saving work as a clinician, making the connection between vitamin A deficiency and childhood mortality, to his leadership as dean of the Bloomberg School for over a decade. Dr. Sommer has been a tireless advocate for improving public health by promoting adoption of medical discoveries into clinical medicine and public health practice. We hope you can join and participate in this special Alliance discussion. Thank you again for joining us today. Have a great rest of your week.